Yeah, like what did you do, Nico, in undergrad?
Like outside
Just for fun, you know?
Just for fun. I did a lot of sports because when you sit and study for many hours in a day, his mind body needed to do something where I was producing, getting tired of. So I did
Aren't you big into rock climbing?
Yeah. Just remote. I used to go and climb mountains.
I did a lot of IM sports as well. I was on something called Green Key, and I was at Dartmouth as an undergrad, which was a service organization, which I was involved in, and I wrote for the Humor magazine. Some of my most gratifying times were writing articles for the Humor magazine.
So I have a question for all three of you, but particularly Steve. So being an MD, PhD, you're sort of stuck between two worlds, like the world of being a doctor and the world of being a scientist. The scientist is always trying to figure out the why a treatment works, not just that it does. And then the doctor is just, oh, okay, like it's working, so we're going to keep doing this for you. So do you think there's like some stigma associated, or is it like tough being in that middle position, trying to straddle both?
Maybe yes and no. I see medicine moving towards what's called evidence-based medicine. And so not just doing something because we have done it, but because we know it works. And there are actually an unfortunate countless number of examples where the tried and true method of, say, you have a heart attack, you're not getting enough blood flow to your heart. Let's give someone a drug, nitrous oxide, that will dilate your blood vessels so you can get more blood flow to your heart. That just, anybody could say that seems to make sense. So we gave nitrous oxide, NO, for a long time to people with heart attacks, thinking that it saved lives, until finally someone talking with, collaborating with the School of Public Health, not ours, but a public health minded person, ran a controlled trial that said, let's not give it to some people and see what happens. And we were killing people by giving it to them, even though it makes perfect sense. So I think that's I would maybe say the PhD side, the why or the evidence side. And for a long time, doctors have prescribed medications or done things because that's how it was done before. But I think part of this healthcare reform is transitioning to let's have evidence-based, science-based medicine, and perhaps as an MD, PhD, you can bridge that gap or be one of the communicators between the old and the new. So I sort of shied away from the question, I guess, but I see the future of medicine as not mean we're doing this because we used to do it.
Can I give you an answer to that? And this is obviously an outsider to it, but I know lots of people are MD, PhDs, and lots of people are one or the other. I think not only is there not a stigma, I think it's quite prestigious to be both. All of the people who are on the tenure track faculty at U of M Medical School have to be doing research. Many of them are just MDs, okay? There are departments, the science departments in the medical school, that have a lot of people who are just PhDs. And I think it's probably fair to say that the just PhDs in the med school context are a slightly lower level in the pecking order. The MD, PhD has prestige associated with it. It gives you training that the MDs don't get that is, I think, invaluable for research. The thing I've always been amazed by, I think the reason that so many physicians are good enough as researchers is simply because they're very smart and adaptable people. Medical school training is diametrically opposite doctoral training, PhD training. It's the exact opposite thinking process. So in medical school, you have to memorize a lot of things. You have to learn. Think about the process. You're a doctor. You've got to make snap judgments based on incomplete information. You've got to make an immediate decision based on incomplete information. The true researcher is exactly the opposite. They want to get complete complete information and there's no real pressure on them time-wise. Take another month, take another year. You want to get it right. So from a thinking process point of view, it's the exact opposite. And I think if you've got the stamina to do the number of years that poor Steve here is going to have to do, and I would also say probably I would never recommend doing that combination unless you want to go into academic medicine. And if you do want to go into academic medicine, I think it's a very powerful combination.
I have a question about something that you mentioned at the beginning about controlling food so I talked about food stamps and how there's taxes on like junk food and things like that. How wouldn't someone's income influence the amount of junk food they buy, assuming that junk food is cheaper? How does that factor into the plan that you proposed or you spoke about with taxes on that?
It's a great observation. We know for sure that people who are less affluent are tending to eat much less healthy diets because they can afford them.
Mm-hmm.
I mean, the caloric content of junk food is much higher and it's much cheaper to make. Think about fruits and vegetables, which are very expensive, very low in calories, and if your objective is to fill your belly up, that's not a great way to do it. And I was mentioning the other day that, or maybe that was even today, I don't remember what day, time flies. One of the things that I think we need to think, it wasn't today, one of the things we need to think about when we talk about organic fruits and vegetables, and they're great, is it's a very elite kind of business to be able to afford those.
Yes.
Okay? So if what you were going to do is simply take the food stamps or the equivalent that you were giving to people and sort of turn around and say half of them have to go for fresh fruits and vegetables, that's not fair to them. Because you are cutting off the caloric intake they can buy with their stamps. So I think what you need to do is probably increase the aggregate amount that they buy, or have some kind of a matching program so that if they use stamps for fruits and vegetables, the government or some agency will pay half of the price itself. But you have to supplement it somehow. That's why I was suggesting that having a tax that would generate additional revenue to support that, which government doesn't like doing. They don't like setting taxes where they're earmarking the funds toward a specific expenditure. But that would be a way to do it. So your point's very perceptive. It would not be an easy thing to simply say a quarter of it's got to go to fruits and vegetables. That would not be fair.
Another way maybe would be to tax the big corporate that are making millions just selling the junk food, right? Because they will stop them taking.
Not in this country.
No?
Not now. We're doing the opposite. We're going to cut down the corporate tax rate. Excuse me, I don't mean to sound like a Texan or something. If anybody here is from Texas, I apologize. No, I mean, sure, you could do that, but what the clearly government is moving toward now is reducing taxes, not increasing them. So that's a hard one. I think it's easier to think about the product as an object of taxation.
This is quick, like, so as a professor of public health, how do you draw the distinction on these health issues between kind of people's rights, you know what I'm trying to get at here, because there's obviously a big issue with some people might feel oppressed by having to buy taxes that are put on healthy foods, for example. So where do you kind of draw the distinction, in your opinion, between citizens' rights and then
First of all, that's a great question, and I think one of the weaknesses of the field of public health is that, first of all, politically speaking, many more people in public health are on the left wing than the right wing. Okay, many more. And I'm sort of a middle of the roader, and therefore a lot of people think I'm a right winger because I'm in the middle. I think a lot of us in public health don't